The goal with this video is to demonstrate and describe the proper technique for lower extremity proprioceptive neuromuscular facilitation. PNF is a valuable treatment tool to help work on neuromuscular coordination throughout the lower extremity. For your PNF to be effective, make sure you follow the general guidelines for manual contacts and resistance, patterns of movement, proper verbal cues, and proper body mechanics. For lower extremity PNF, your patient should be positioned in supine and gently scooted towards the edge of the plinth on the side you'll be treating. Depending on which pattern you'll be using, your treatment leg will either start in an abducted or an adducted position. Similar to the upper extremity, the lower extremity has two main diagonal patterns. Motion can occur either into flexion or extension for each pattern, for a total of 4 basic lower extremity movements. Even though motion occurs at multiple joints throughout the lower extremity, the 4 movement patterns are named by the direction that the hip is moving towards. Along diagonal 1, we have a flexion and an extension pattern. Because of the motion of the hip, our diagonal 1 flexion pattern is named flexion, adduction, external rotation. And our diagonal 1 extension pattern is named extension, abduction, internal rotation. For diagonal 2, our flexion pattern is named flexion, abduction, internal rotation, and our extension pattern is named extension, adduction, and external rotation. The clinician facilitates movement in each of these directions by providing resistance in the opposite direction. So let's go over each pattern in a little more detail. Our first pattern is D1 flexion, or flexion, adduction, external rotation. The motions we want to facilitate include hip flexion, adduction, external rotation, knee flexion, ankle dorsiflexion, and foot inversion with toe extension. As with any PNF pattern, the goal of our manual contacts and our verbal cues is to facilitate the proper movement. When providing resistance for the lower extremity musculature, the clinician needs to make sure that they use good body mechanics and that they pivot and shift their weight instead of twisting through the trunk to control the leg. For the distal hand, the proper location for manual contact is on the dorsal foot with the fingers wrapped to the medial side of the foot. These contact points can help facilitate knee flexion, ankle dorsiflexion, foot inversion, and toe extension. The proximal hand should be placed on the anterior medial thigh just above the knee. The proximal hand helps facilitate hip flexion, adduction, and in concert with the distal hand, external rotation of the hip.
Okay. Foot up. Pull your knee up and in. Good. Foot up. Pull your knee up and in. Foot up. Pull your knee up and in. Foot up. Pull your knee up and in. Foot up.
At the other end of our D1 diagonal, we have our extension, abduction, internal rotation pattern. So by name, our hip must be moving into extension, abduction, and internal rotation. The knee moves into extension, the ankle moves towards plantar flexion, our foot moves towards eversion, and our toes flex. The clinician facilitates this movement by placing their distal hand on the plantar surface and the lateral side of the foot. In this position, the distal hand can provide resistance into ankle dorsiflexion, foot inversion, toe extension, and knee flexion. The proximal hand is placed on the posterior lateral distal thigh just above the knee. While the proximal hand pushes into hip flexion and adduction, both hands will apply an external rotation force to the hip.
Push your foot down, kick down and out. Push your foot down, kick down and out. Push your foot down, kick down and out toward knee. Push, push. Push your foot down, kick down and out.
The first of our D2 diagonal movements is flexion, abduction, and internal rotation. These hip movements are accompanied by knee flexion, ankle dorsiflexion, foot eversion, and toe extension. It's important to make sure as the hip moves into flexion and internal rotation that the patient doesn't complain of any symptoms of impingement. The distal hand is placed on the dorsal lateral foot, while the proximal hand is placed on the distal anterior and lateral thigh just above the knee. With these hand positions, the clinician is in a position to provide resistance to facilitate the wanted motion. Proper motion is also facilitated by the use of specific verbal commands. In this case, foot up, lift your leg up and out.
Alright, drive your foot up, bend your knee up and out. Okay. Foot up, bend your knee up and out. Again. Foot up, bend your knee up and out. Okay, one more time. Foot up, bend your knee up and out.
Finally, we have our D2 extension pattern, which includes extension, adduction, external rotation of the hip. These hip motions are accompanied by knee extension, ankle plantar flexion, foot inversion, and toe flexion. For this pattern, our starting position will be in hip flexion, abduction, and internal rotation. The distal hand contacts the plantar foot and the medial foot to facilitate our plantar flexion and inversion motions. It can also provide a push into knee flexion, which helps facilitate our knee extension. The proximal hand is then placed on the posterior medial distal thigh. This location allows the clinician to facilitate hip adduction, extension, and external rotation.
Okay. Push your foot down and kick your foot down and in. Push your foot down, kick your foot down and in. Push your foot down and kick your foot down and in. Push your foot down, kick your foot down and in. One more time. Push your foot down, kick your foot down and in.
So here is a summary of our 4 different lower extremity PNF patterns. The functional deficits of your particular patient will help dictate which pattern is appropriate to use. As with any PNF pattern, emphasis can be placed at any particular joint where the patient may have more difficulty. Specific emphasis can be created by the clinician by altering the amount of resistance they use at a particular joint and by modifying their verbal cues.